Well, thank you very much. Um, Before I start, I just want to thank everyone for asking me to speak today, and it is really my privilege and an honor. And I wish this was in person, so I can get to meet many of you who are watching this presentation. Today, I'm going to talk about the liver transplantation for intrahepatic cholangiocarcinoma, and I want to say that a lot of this work has been done in collaboration with MD Anderson, and that this work is really in its infancy. So I'm just going to start with a couple of slides to put it into perspective. So traditionally, if you get cholangiocarcinoma inside the liver, we used to think of it as a resection where we take out part of the liver. So, but however, most of the time when this presents to us, less than 30% of the patients present with resectable tumor at the time of diagnosis. Even after resection, the results are not great. They're getting better, but they're not great. The survival rate varies between 22 to 44%. And a lot has been thought about what causes what are the causes that resection is not that great. And a lot of things that were mentioned. Part of it is what we call microvascular invasion, which is the presence of the tumor cells around small blood vessels and the tumor, the presence of enlarged lymph nodes, bigger tumors greater than 5 centimeters, and multiple tumors, and that the resection does not clear the whole tumor. So what about chemotherapy? There has been a lot of advances in chemotherapy, and today I think becoming very standard is the combination of gemcitabine and cisplatin. And if you look at it, the progression-free survival has improved from 6.7 months to 8.8 months, and the overall survival has improved from 8 months to about 11.6 months. That is significant statistically. However, the change itself in the time is very small. Nevertheless, those studies have shown us the way that chemotherapy and what chemotherapy can be effective. So I want to go back and give you some sense of what were the previous efforts that were done, for transplantation. This slide comes in from efforts at UCLA a long time ago, and they looked at a combination of all the patients that they transplanted for cholangiocarcinoma, and this is shown in the straight line, and OLT is orthotopic liver transplant, and they looked at it compared to the patients, the survival of the patients who underwent resection, and all patients that were transplanted did better than resection. Now, you also have to know that in the transplant area, that included everybody with cholangiocarcinoma. That was hilar, which is outside the liver, and also intrahepatic, which is inside the liver. Now, they looked at the role of chemotherapy, and they saw that, and this figure on the A plot here is really one of the very important figures that you want to see. So this is the patients who underwent transplant, and there were three different categories. Patients that did not receive chemotherapy alone, and they all did very poorly. Patients that received chemotherapy before the transplant, and they did much better. And then the patients who received chemotherapy after the transplant and did a little better than without, but not a great improvement. And the lesson here is that the addition of neoadjuvant therapy or pre-transplant chemotherapy does improve the survival. In the resection, there were no patients who received chemotherapy before, and the results of the resection still are not good even with adjuvant therapy. But there are other, we are working on other modalities to make it more successful. So multivariate analysis, what are the significant factors that influence outcome? So liver transplants perform better than resections. Tumor location, intrahepatic actually perform better than hilar. The tumor histology, if you have any invasion of the tumor into the nerves, all the blood vessels, or multifocality of the tumor, where you have multiple tumors in the liver, the risk ratio was very high, and the tumor size was important. So these were the outcomes of UCLA without chemotherapy. Now Gonzalo from Toronto, Sapisochi, went and looked at all the transplants that were done for cholangiocarcinoma over a very long period of time in Europe, and just I want to say that people, or in general, we do not go and transplant for indication of cholangiocarcinoma. So these cholangiocarcinomas were found after taking out the liver for transplanting for any other reason. So looking at it, if the tumor was less than 2 centimeters versus tumors of greater than 2 centimeters, so recurrence rates were a lot lower if the intrahepatic tumor was less than 2 centimeters. And then if you look at survival, the patients who had tumors less than 2 centimeters approached about 65% to 70% survival in 5 years, where patients with greater than 2 centimeters fell down to about 40%. So here the lesson is size matters. So let's look at the lessons from the previous literature. That neoadjuvant therapy or chemotherapy given before transplantation is very effective when combined with a liver transplant. Liver transplant for selected patients can be successful. The question is, who are the patients that should be selected for transplant? So now we know that because resection is the first-line therapy that is utilized for intrahepatic cholangiocarcinoma, currently liver transplant is applied after in patients who could not be resected. So it usually is applied to patients with a very large unresectable tumor. So that's what we did. We thought that 6 months of neoadjuvant therapy, and if the tumor stabilizes under this, then we will consider this as an appropriate surrogate marker that this tumor is amenable to treatment and biologically responsive tumor, and we will select those patients for a liver transplant. And that's what we did. I'm just going to go through some scans of the patients who gotten transplanted for cholangiocarcinoma. And if you look here, this is the liver, this is the spleen. That's a CT scan section of the patients. And in this tumor, it extended here all around. So it was in the left side and the right side of the liver. Obviously, you cannot cut the liver, because if you cut the liver like this, take this out, you take it out with all blood vessels. That doesn't work. This tumor as well extended in the left lobe of the liver here and then the right lobe of the liver, so is not amenable to resection. Multiple tumors, so you really have to take out the whole liver. Again, a liver that's after resection, and this is a residual tumor or a recurrence tumor. A liver also after some resection and then recurrence here, and then again here multiple tumors. So these are patients who underwent transplantation. So transplant at the present time can only be applied or is only applied to patients who could not be resected, and they usually come to us with very advanced disease. So what do? We start them on neoadjuvant therapy. This is Gem-Cis, platinum-based, and then if progression, there's a second line of chemotherapy. And then we are looking also at some target biologics on case-by-case basis. But in general, we look at the progression of the tumor under Gem-Cis. If those tumors are stable for 6 months, and during those 6 months we repeat every 3 months imaging, we put them for a transplant, and then we see the outcomes. So, how many patients did we see? And this is an updated slide. We have had a lot of people come to us, and we're very grateful for that. We had about 65 patients. Only of those, 37 patients were listed for a transplant, and they were declined for many reasons. But most commonly, they did not want to be evaluated, or the extent of the disease was too big for a transplant, or there are other issues, medical issues that could not allow the transplant episode to happen. While on the waiting list, there were 5 patients that underwent resection. So we ended up by having 18 patients so far getting a transplant and 14 patients not getting a transplant. And the 14 patients not getting a transplant, 2 were aborted at the time of transplantation because of the extent of the disease, and 7 are currently waiting for a transplant. So demographics, age of the patients usually is about 42 years of age, so they're quite young. BMI of 25. Most were males, Caucasian. PSC is actually very interesting, and only about 30% were PSC. Some were diabetic. Their MELD scores at the time of a transplant, and a MELD score is a measurement of how sick somebody is from the liver. So if your MELD score is 6, that you're normal. If your MELD score is 40, then you are in liver failure, and usually you are in intensive care when it's 40. And then different grades based on that. So most of the patients, or all the patients that come to us, for treatment with cholangiocarcinoma have very low MELDs. So these are the donor demographics. And because those patients have very low MELDs, and the allocation policy allocates the livers first to the very sick people. So it goes into MELD score of 40 and then 39 and then 38. And that actually is a regional list. So our ability to get livers for them is limited. And what we can do is we utilize livers that were not suitable to transplant in other patients and or using living donors. So these are the tumors sizes before going into transplant. On average, the number of lesions were 2. However, they varied from 1 to greater than 5. The maximum size of a single tumor was 7.4. However, they also varied from 2.6 to 10.3. And the total diameter of the tumor on average was about 10.4, but it varied from about 5.7, 5.8 to about 14.5 centimeter tumors. So in essence, this is the radiological characteristics of the tumors. These were huge tumors that we were dealing with. Post-transplant, I'm going to go into the median. The median number of lesions were 3. Maximum size was 6.5. Total diameter of the tumor was on average 8.5. And these are all averages. And you notice here some of the tumors were about at least 20 centimeters. These are massive tumors. Some were bilobar, some were the left side. Some had lymphatic invasion, some didn't. On average, not. Perineural invasion, no. And microinvasion, some had, but the majority did not. Nobody had positive margins. And when we look at the tumor, there was only 1 patient who did not, 2 patients who did not have necrosis of the tumor as a result of chemotherapy and other modalities. This was only, the data was present only in the first 9 patients. However, we're compiling the data for the rest of the patients. So this were the original transplants outcomes, and the 5-year survival rate was about 80%. Patients who are starting at the time of listing who are not transplanted, they have a survival of about 18 months. And now this is our new or expanded outcomes. Our overall survival, this is a large number of patients, is about 60%, a little higher. And again, we see an average survival of about 18 months for patients who did not get a transplant. Looking back at recurrence rates, about 40% of the patients do recur. The time of recurrence is about halfway, about two and a half years. However, a lot of people are still alive despite the recurrence. If you recall, those patients do have tumors that are responsive to chemotherapy, and there are a lot of modalities that we use to treat recurrence. So despite recurrence, they're alive and doing well. One of the areas that we're looking into is the genetic mutations of the tumors. We have previous data suggested that if you have a genetic mutation with FGFR, you do better than if you don't. And if you have a KRAS, you do worse. The KRAS, which is green, you do worse than the ones who do not have KRAS. And that those biological markers or genetic mutations can be maybe used in the past for selection of patients. So if we look here of all the patients that we have some markers on them, most of the patients over here have had good markers that we think are biologically responsive tumors. For example, the FGFR mutations here, and the IDH1 is also a good one. So, and only 1 or 2 patients had the KRAS. So, in essence, the genetic mutation analysis can provide us with some idea who can we select. So, all in all, liver transplantation is still in infancy for that tumor. It reminds me a great deal with what we went through, not in cholangiocarcinoma, but hepatocellular cancer. In hepatocellular cancer, 20 years ago, the first outcomes, the first results were very poor. Today, liver transplantation has become the preferred methodology for hepatocellular cancer or hepatoma. So liver transplantation can be performed successfully in patients with unresectable intrahepatic cholangiocarcinoma with excellent outcomes. We think 60 or 80% survival 5 years out after this diagnosis is very good compared to any other modality. Well, liver transplant exhibits survival advantages when compared to resection at any stage. The results of this case series, this was the original case series that we did with about 7 patients. Now we did about 17, so we're adding numbers. And also I have to say that there's some other centers around the country started looking at this data and applying transplantation for their patients. I get called about whether we should or should not do some patients all the time. And then new adjuvant therapy and genetic mutations can be utilized for patient selections. And I'm going to stop here and see if there are any questions that I can answer, if there are any. So the first question is from Jordan. Have you successfully received cholangiocarcinoma mild exception points? No, if we ever receive, we have not been able to do that, but there's a lot of discussion of how we do it. So far, we do not get mild exception points for patients with cholangiocarcinoma. And then somebody was asking me if I'm ready to go on, and I'm ready. So whatever questions you want to send me, please do. Have there been successes with transplantation after a prior resection? Yes, we've had several patients who got recurrence after resection, and we transplanted those, and the most are doing very well. You have to know that liver transplantation in general is a complex operation to do, and if you had previous irradiation or a previous resection, it just complicates the transplant operation itself. But so far, we've been successful in transplanting those patients. So there's another question. When is transplantation for perihilar cholangiocarcinoma warranted? 2, is transplantation after resection an option for some after survival rates for transplantation overstated when compared to resection, since the bar for transplantation is so high? These are all excellent questions, and let me try to take them one by one. When is transplantation for perihilar cholangiocarcinoma warranted or possible? So hilar cholangiocarcinoma was considered for transplantation by Mayo Clinic and popularized by Mayo Clinic many years ago. And when they started, they were criticized. However, with time, now we know that the criteria for it, we do screening for patients with some. We do laparoscopy. You look at the size of the tumor, and those patients always get chemotherapy and sometimes targeted irradiation. We've done several without irradiation, and they do as well. However, if you have a tumor that is less than 3 centimeters, you do get exceptions on the list, and you probably would get a transplant depending on where you are in the country in about 6 to 9 months. So with perihilar cholangiocarcinoma, we do very well. Is transplantation after resection an option for some? Yes, we've done that successfully many times. Are survival rates for transplantation overstated when compared to resection, since the bar for transplantation is so high? So I think that the bar for transplantation is very high because you are dealing with tumors who cannot be resected. And these are massive tumors that we do it, which is about 10, 14 centimeters. It's a huge tumor. If you resect such a tumor, the results are not good. Now, we're transplanting people who could not be resected. So by definition, we're dealing with the with aggressive tumors. So if I was to choose, I would start transplanting people at 2 or 5 centimeter tumor. I would imagine that the results would be really excellent, much better than we have today. Could you please recap? What qualifies a person for liver transplant? The hilar cholangiocarcinoma is different from the intrahepatics. The intrahepatic for us, if you are on chemotherapy and the chemotherapy will provide you 6 months stability, then we will consider you for a transplant. What is success rate for perihilar cholangiocarcinoma? Success rate is excellent. The survival rate was shown to be about 95% after 1 year, and I believe it's about 70% 3 and 5 years out. So they do very well. What is your thoughts about adjuvant therapy after transplantation? We employ adjuvant therapy after transplantation for tumors that we think are aggressive after we take them out. However, I'm not sure that I would say that we think that the benefit is small. However, that's all that we can do now. So we do our best to prevent recurrence. So we do employ it after transplant. If lymph node involved not eligible, my goodness, my daughter has that. This is a tough one to talk about, because if you in general it is no, we do not like to work on people with positive lymph nodes. However, if you have someone who is young and has been responsive to therapy, and we're able to clear those lymph nodes out with the taking the tumor out with the liver, we would consider it, especially if there is targeted therapy. So I would say that this is something that we have to think about based in a case-by-case basis. And the reason we think about it is if it's spread out of the lymph nodes, then it's advanced. However, the hepatocellular cancer on the other side, even if there is perihilar lymph nodes or lymph nodes next to the liver that goes out with it, it does not affect the survival. So this question about the lymph nodes is something that we're working on, and I would say we have to consider this case-by-case basis. They tried to resect my tumor, but they discovered nodules in the peritoneum, and the resection was canceled. Is transplantation an option? It is hard for me to say, but in generally, we do not consider transplantation for tumors outside the liver. Is having lymph node involvement an automatic no to being considered for transplant? I did cover that. It is not an automatic no, but it makes things really tough. And depending where the lymph nodes are, if the lymph nodes are close to the liver, can be taken out, and the tumor is responsive to treatment, we think about it, definitely contemplate it. And I want to tell everyone that we are still in the infancy of doing that. A transplantation option for patients with a single large tumor, 10 centimeters, yes, it is an option. We have taken tumors out that were about 14 centimeters or bigger. As long as this tumor is under control with chemotherapy, then we consider doing that. If the tumor is extended from the liver into the IVC, would the transplant still be an option? This one, no, because we will not be able to benefit you. We will not be able to provide benefit, and sometimes the operation is almost undoable. Do all patients post-transplant need to go on chemotherapy post-ORT? No, not all of them. The ones that we see that they harbor aggressive tumors, we send them for transplant. Excellent presentation. What is the evidence of giving neoadjuvant chemo to these patients for 6 months? The evidence is what we have done. Is that written in stone? No. What we have done at the beginning is that we looked at the data that's around, and we understand that if there is neoadjuvant therapy plus transplant, the results are better. So we sat down with several people from Anderson. Milan Javli was involved in that to write a protocol, and we had several meetings of what's the best to do, and the best way at the time to consider how to show that the tumor is biologically responsive is its response to chemotherapy. So that's why we decided to do it. We chose 6 months. I think this was Milan's thoughts. They probably want to ask him why. However, we in general want to see that the tumor is in check, so it's at least 3 to 6 months doing that. We tend now to list the patients earlier than later, because we end up spending some time trying to find the liver. So I think after initial response, we list the patients and wait and scan them while they are on the list. These are just different approaches to expedite the process of transplantation. My husband had an ERSP last week and stents put in the hepatic duct and pancreatic duct. The doctor wasn't able to get a biopsy. He's having a second RCP, the spyglass next week to get a biopsy of the mass. A radiologist would do a CT scan, got a biopsy. Would that jeopardize any chance of liver transplant for the future? That risk favoring sending cancer? That is an excellent question. And for a lot of times, we may not be able to get a biopsy for it. And we do several screenings to be able to find cells to indicate whether there is or there's not a tumor. A biopsy would be fantastic because it gives you assurances of the transplant, but in general, that is not an easy place to get a biopsy from because it sets down on the hilum. If you're talking about that, so a lot of times we will have to depend on the radiological pictures and on the aspirates from the bile duct itself. That is often a problem that we come across. And when we see that, we tend to follow the patients and see how they're doing. What if a protocol and then laparoscopy shows in one node after imaging and shows no other spread, and more chemo shows no spread after several months? Would transplant be an option? Yes, we would evaluate you for a transplant then. You mentioned the average age of the transplantation. You mentioned the average age on the transplantation was in the 40s. What is the success rate with someone older, say in the 70s? We would still. So this is an excellent question. We have done a lot of transplants for perihelion cholangiocarcinoma for patients of the 70s. If you're in good shape, we would consider it for transplant, no question about it. Good morning, Dr. Ghobrial. Thank you for your dedication. Thank you. I flunked my LT608. I had 4 enlarged lymph nodes at some of my liver. So my question is, what makes you happy? I guess that has to do with the presence of lymph nodes. Is not all. What I have to say is we're still learning how to do it, and we're not perfect yet. The other question is on immunotherapy. Is recurrence post-transplantation resectable treatable with immunotherapy? I've previously asked and been told minimal success with immunotherapy on transplant patient. Thoughts? This is truly thoughts. There's nothing there. So immunotherapy is currently being applied at the beginning, and then the issue with before. There are some protocols where you may be able to give immunotherapy to the tumor to try to shrink the tumor before you get into a transplant situation. We don't know what the outcomes are yet. Immunotherapy is thought to have an incredible effect. So that is still tried. We have not done transplantation for somebody who has had immunotherapy. Although the issue here is if you give immunotherapy, that's supposedly to upregulate or rev up the immune system to kill the tumor. So if you come in and do a transplant right after that with a very aggressive immune system, the transplant may get rejected. So the question here is that going to happen after immunotherapy with the transplant, or you need a wait period, and how long is that wait period? So there's a lot of unanswered questions of immunotherapy prior to transplantation. Post-transplantation, there are some, there's very few cases. Some say it is not going to be good because the organs are rejected. Others are saying it will be okay. We can override that rejection. So this is very at the beginning. We really don't have a good way of employing immunotherapy with transplant so far. But I can tell you that we have applied for a couple of protocols, and we're working with a few of the companies that have supported supporting this conference to see what effect we can do. Would you consider a candidate with arterial involvement stable on chemotherapy? Usually, arterial involvement is not good, and you end up with a metastatic disease. So for now, I would say no, we would not. Do you use live donors for partial transplants? Yes, I think the ideal situation is to get treatment and have 6 months stability. You get a transplant. A live donor transplant would be the good way to go. And we have not done live transplants in Houston for one simple reason: we were not sure whether transplantation would or would not succeed. So to put a live donor at risk for a transplant that may not work well was difficult for us to justify. Now we know that in selected cases, transplantation does do well. Transplants do very well in some occasions. then there is reasonable justification to use a live donor on the liver side to be able to do the transplant. Remember, a live donor has about a little less than 1% chance of dying through the surgery. So living donors in the liver cases are not that straightforward. But I think today, if you come and you have a live donor and you want me to do a transplant for him, I would do that. And I think there's agreement around the country that this is a good thing to do. Taiwan has living donor liver transplants, which are very successful. Has this been considered in the US? Taiwan has no other way of doing transplants other than employing living donors, because the cadaveric donation there is extremely poor. So we have done living donation in the United States. I think about 5% of the transplants, or a little less, are live donor transplants in the liver world. And today, I will tell you that we would consider doing we would be agreeable to do a living donor transplant for intrahepatic cholangio, because we know that those patients do well. So there is justification to put the patient through the operation of donation. At Houston, because of the COVID issues, we have not implemented the living donor yet, but once we know that the COVID problems are almost closed, then we will start. Taiwan, having spread to one node but shows stability, would MELD score be high enough to decrease donor transplant, or would you need a live donor? So the MELD score is a composite score, a mathematical score that is based on bilirubin, creatinine, and INR. INR is normalized ratio. It shows how quickly the blood clots. So a patient with cholangiocarcinoma usually has a normal INR. Usually the kidney function is good, the creatinine is good. It's not affected by diseased liver, and the bilirubin is normal, maybe elevated. So that would not give you a high MELD score to be able to transplant you. The only way that you can get transplanted through the pool is to have exceptional points, or you get a liver that no one else wants to use. It doesn't mean it's a bad liver. It could be not utilized for others because of size or a lot of other reasons. So would you need a live donor? A live donor would make the issues straight. So they told me that I'm over and I need to wrap up. So I just want to thank everyone, and I'll tell you, my heart goes out to all of you. And all I say is that we're going to do our best to be able to get this transplant program, up and running and doing more patients. So I thank you for your time, and hopefully you enjoy the rest of the conference. Thank you very much.